Minute you're on. Oh,
So Dick, you start.
Yeah, that's correct.
You ready?
Go ahead, Dick.
Okay. Welcome everyone to day 3 of the Bloodless Medicine and Surgery Week 2024. My name is Richard Burstrade. I will be one of the moderators for today's session, along with my colleague, Dr. Tina Kalu. I serve as the nurse coordinator for the Bloodless Medicine and Surgery program at MedStar Georgetown University Hospital in Washington, D.C. So May has been designated as a Bloodless Medicine and Surgery Awareness Month. It is so designed to raise awareness that bloodless medicine and surgery is a superior form of healthcare. This month, and this seminar was organized by the Bloodless Medicine and Surgery Group at the University of Calabar in Nigeria, in collaboration with the Bloodless Medicine and Surgery Society, the Society for the Advancement of Patient Blood Management, SABM, and the Malaysian Society for Patient Blood Bank. The theme of Bloodless Medicine Surgery 2024 is bloodless care in oncology and palliative care. Today, the focus of our session will be strictly on palliative care. I'm very excited to hear our experts speak today. When I started as a critical care nurse many, many years ago, palliative care did not exist at our hospital. It's a relatively new program for us, but a very important addition. When palliative care started at Georgetown, there were 3 employees that were running the program. It has now blossomed into a vibrant team of 10 people of various specialties. And over the years, I've worked closely with them, and they provide a great service to our bloodless patients and family members and to all our patients in the hospital. They're really, really an important part of our medical team here at MedStar Georgetown University Hospital. I would now like to introduce my fellow moderator, Quinnet. Hello.
Thank you very much, Dick. I want to join earlier speakers to welcome everybody to today's session as we mark this year's Bloodless Medicine and Surgery Week. It promises to be an exciting session. We're going to have 3 talks, one a keynote address, and it will be titled Palliative Care and Ethical Requirements in Oncology. We have 2 other talks, one pain management in oncology, and the second one, controlling gastrointestinal symptoms in cancer patients. As I welcome you all, be informed that the program is also being live streamed on YouTube. So in case you're having difficulties with your Zoom link, check in the chat and you will see how to migrate to the YouTube. Again, you can just type in Bloodless Medicine and Surgery Society on your YouTube channel and it will take you right on to the meeting if you do a search for it. At this point, I want to inform all of us that there are a few housekeeping rules. In the course of the presentations, if you have questions, kindly put them in the chat. Apart from that, avoid or minimize chats so that you don't distract other speakers and attendees at this meeting. I would go ahead and introduce the keynote address speaker for this meeting. Our keynote address speaker is no less a person than Dr. Kyriakos Stylianides. I've taken time to learn how to pronounce this name, and I hope I got it right. Dr. Kyriakos Stylianides has been practicing palliative care in Cyprus since 2006. He graduated from the Ovidius Medical University of Constanta in Romania in 1999. And then from 2000 to 2001, he worked as a junior doctor in the Bank of Cyprus Oncology Center in Nicosia. And between 2006 and 2018, He worked at the supportive care unit of Bank of Cyprus Oncology Center as a palliative care doctor. During this time, he did several courses in palliative care, including Essentials in Palliative Care from Prince Alice Hospice, Communication Skills course, and 2 months fellowship in San Diego Hospice. From 2015 to 2017, he studied for a postgraduate degree in hospital management at the Open University of Cyprus. And in November 2017, he was awarded the bachelor degree of health units management. Since November 2018, Dr. Stylianides has been employed at the Pan-Cyprian Association of Cancer Patients and Friends as the medical director. In March 2019, he spent a month in Ohio State, where he was trained in palliative care for children. And he's been providing services for palliative care patients through Cyprus National Health System, and both hospices are directed by him. Dr. Stylianides lectures 6th-year medical students in palliative care at the Cyprus Medical School. He participates with ASCO as a facilitator in education for palliative care around the world. He has participated in several master classes for palliative care, both in organizing the master class and as a key presenter and facilitator, both in Cyprus and abroad. Dr. Stylianides played an important role in establishing legislation for palliative care in the island of Cyprus. He convinced the Ministry of Health that palliative care should be part of the national health system, and it should be offered to adults as well as children from the beginning of their diagnosis. His main goal was to make palliative care available for all the patients that needed it all over Cyprus. Dr. Stylianides is the first doctor registered as a palliative care physician in Cyprus National Health System. Ladies and gentlemen, colleagues and participants around the world, please join me in welcoming our keynote address speaker, Dr. Kyriakos Stylianides. Welcome, sir.
Thank you very much. Thank you very much, Gwyneth, for all your nice words. I'm very honored, and I also feel privileged that I'm given the chance to talk about palliative care, not only in my country, but all over the world. And I felt very excited when Dr. Nathaniel Soro asked me if I could give a talk about the ethics that are raised when we are dealing with palliative care of our patients. And it's something that, unfortunately, in the modern world, we don't pay so much attention. And I feel that after I give my speech and I present you a few things, you will understand how important it is that we should always consider the needs and what our patients want, and not about our needs as providers, and not what we wanted. We should pay more attention to the needs of our patients. So by saying that, I will share my screen. So what we will talk for the next half an hour, it's the ethical requirement in oncology for palliative care. I have a short film, which I think it will give us an understanding why it's so important to consider ethics when we are talking about palliative care?
One of the things we want to bring around the end of life is dignity. We want people to die with dignity and quality of life. If you talk to anybody who have lost a loved one, the greatest regret people have is that I wish I said goodbye. I wish I spent 10 minutes with my dad and told him how wonderful he was. And I regret that personally because my dad passed away in great pain. His pain was not controlled, so he died in a lot of pain. And there was no opportunity. He could not even comprehend who was there with him when he died. And I think that is a regret for all of us. When we lose our loved ones and they're in so much pain, they're wailing and screaming, they did not even know you were there. So it's just providing that dignity and an opportunity for people to put their business in order. Because at the end of life, your value as a human being does not stop.
Many people ask, what is palliative care? I see it simply as therapeutic interventions to try to relieve and even prevent issues that cause suffering.
Palliative care is whole person care.
To try to avoid pain, or when it starts, to manage it well, to deal with many other symptoms that I might experience.
It takes seriously physical, psychological, social,
Anxiety, depression, challenges within my family.
existential, spiritual, financial issues.
Spiritual questions. Why me? Where's God? What about the meaning and value in my life?
It recognizes the profound importance of Sisley's term, total pain.
To help me manage the advancing illness as I approach the end of my life, to help me prepare for the end of my life, and specifically to manage all of the issues that arise during the dying process so that I can feel as comfortable as possible and have a safe transition as I die.
Whole person care is a central concept, but the foundation of the edifice of whole person care is excellence in physical care, good nursing care, good, knowledgeable, available medical input. This is not a place for amateur night. These are the sickest people in the healthcare system. They deserve the best care.
Between the hospice people and my doctor and the others, the nurses, specialists, they've turned me around so that I can sit up and I can, it's a marvelous thing.
Thanks to them, we have, my mother has had more days when she is comfortable. And when she's comfortable, we can laugh and joke and have meals together and just kind of treasure this time together. And without them, it would probably be a much different situation.
We have this wonderful profession of hospice and palliative medicine that is an international profession. And so people don't have to go through this alone, that there are experts that can help them to walk through this, and that people do not have to die in pain.
In an age where we're doing such wonderful things in all specialized areas, to then bring amateurism to the sickest people in the healthcare system, it's ridiculous, particularly when we know how much that we can achieve, how helpful we can be.
So when we are talking about palliative care, we have to think that it's a human right for people not to suffer. And I was doing some research also for Nigeria, and we see that there are approximately 100,000 new cases of cancer every year. And these patients, unfortunately, they present at an advanced stage of the cancer when the only treatment options remain is palliative care. And
Excuse me, please permit me to interrupt. Kindly swap your display so that right now we are seeing presenter's view. So you can click on either swap displays or use slideshow.
yeah, okay. Yeah, thank you. Thank you.
Okay, you're welcome.
So we see that in USA, causes of death is the first reason for people that they die in the USA, with which is very close to the first reason, which is cardiac disease, is malignant neoplasm. And then the third reason is by far much less. It's only 150,000 in the USA, and that was a research done in 2004. So you understand that controlling the symptoms, it's our obligation for our patients. And usually the main symptom that our patients have, patients with cancer, is pain. And you can see that the percentage is very high. 84% of those patients diagnosed with cancer, they will have pain. And of course, they lose their appetite, and that's also a very high percentage. And another important problem is the breathing and nausea and vomiting. So all these issues need to be addressed in order to have a better quality of life. Palliative care in most African countries is rudimentary, and most health practitioners have poor knowledge of palliative care. It has been shown that established care, support, and pain control exist only in a few African countries. Nigeria, thank God, is one of them, and it's advancing quite a lot. As clinicians, it's our obligation and duty to ensure the well-being of our patients. Physicians must protect the lives of their patients and should never hasten their death. When we cannot cure an alignment, what we have to do is to relieve suffering, but never abandon the patient or initiate terminating their life. We must promote palliative care and give both psychological support and social support so they can find the meaning of life until the end of their life. The mother of palliative care, Cicely Saunders, which she was a nurse, she started as a nurse. She worked very closely in the Second World War with the soldiers that they were dying. And she found out that not only they were in pain at the end of their life, but they wanted this support, the psychological support. They wanted to send a message to their loved ones. And she was the first person to realize the need and the meaning of palliative care. It was very late. If you see that it was only 1959 that she described in a nursing article about the palliative care and ethics. And only in 1979, there was the principles of biomedical ethics and the respect for autonomy, non-maleficence, beneficence, and justice came into the field. In 1987, I was very late still, palliative medicine becomes a medical specialty in the UK. So it took very long time until we decide that we need palliative care for our patients. And hospice and palliative care recognizes that medicine was failing the dying. So at the end of their life, we didn't do much. We had a bad response to the bad death. Nurses were pioneers in hospice care. And as we said, Cicely Saunders, she was the first one to address the issues about palliative care. And then the medical ethics recognized that medicine was failing the patient, the right to self-determination, autonomy, and patients' rights rather than doctor knows best. And in my word, unfortunately, this story is something that we see quite very often. We don't allow our patients to choose how they will be treated. We make their decisions, and this is very wrong. It leads to paternalism, which is very wrong, and we don't respect the rights of our patients. So the core medical ethics is all about autonomy, which is the most important thing, and the patients, we have to empower our patients because they have the right to refuse any treatment, or they can choose what kind of treatment they want. It's about beneficence, always acting in the best interest of the patient. And non-maleficence, above all, do no harm. Justice, fairness, and equality as to who gets what treatment. All patients are the same and they have the same rights. And of course, never forget dignity. We should treat our patients' family with respect. And fidelity, notions of loyalty, commitment, and trust in the relationship. All these are very important when we're talking about ethics and palliative care, and we should always consider them. Autonomy is about the individual, sovereign self with positive and negative rights, free from interference, and the right to determine one's own life. Our patients are asking us all the time to let them make their own decisions. It's about their life, it's not about our life. And these decisions can include any of these, whether it's treatment, whether it's to resuscitate, to sedate, to go home to die, to refuse morphine, to want better symptom control. Our choices, as Cicely Saunders says, do not take place in a purely individual setting, guided by the principle that life is of value until its natural end, with space for mending relationships and honoring important values by competent, ever-improving care. Believe we should constantly reiterate that this is the way to respect patients and families' true needs. Their autonomy must be seen in the context of society as a whole. And then palliative care came, which is specialized medical care for people with serious illness, like cancer patients. It is focused on providing patients with relief from the symptoms, such as pain, stress of the serious illness, whatever the diagnosis is. The goal is to improve the quality of life, both for the patient and the family. And there have been a lot of changes in palliative care over these few years. It's the active management of a progressive chronic disease and not only malignancy. From palliative care to palliative medicine, we have progressed to this, which means a greater willingness to actively manage disease using medical methodologies, upstreaming palliative medicine to earliest point in the diagnosis of progressive disease. The earlier it's applied, the earlier palliative medicine is applied, the better quality of life our patients will have. There were ethical conflicts involving the principles of autonomy, beneficence, non-maleficence, and justice. The decisional capacity, it was a main problem because the majority of patients, they lose the decisional capacity. Advanced directives. Do you have a healthcare proxy, somebody who can make decisions for you in case you cannot make these decisions? Truth-telling, are we obliged to give the prognosis to our patients if they are asking for it? And informed consent, family asks you not to tell. Something, again, very common in my world, that usually a son, a daughter, tells us doctors, do not tell my father what's going on, do not inform my father that she's dying. Are we allowed to do that if our patient is asking for information about his prognosis or his disease, how it's going to evolve? Factors impacting on ethics in palliative care, the rapidly evolving medical technology, people, they live longer now. The advances in medicine are a lot. So this longer survival, it means that there is increasing burden of disease and functional impairment. There are polarized and scrutinized political and medical legal environment. And also we should consider the awareness of cultural, religious, ethnic, economic, educational, and other diversity. Applying the ethics now to a clinical setting, it's always a medical decision making. We should consider issues of utility, conflicts of value, patient, family, doctor, nurse, and best interest, realistic goals of care, the level of suffering, and the quality of life that the patient will find acceptable, not that we will find acceptable. It's all about our patients. And we should try to restore the balance, because providing a proper and a good palliative care, it means a life-prolonging care. Of course, the potential goals of care is to cure the disease, but at the same time, we should relieve the suffering. We want to avoid premature death, but we should consider the quality of life. Maintaining or improving function, it means also good health, staying in control, and this will prolong life, of course, but at the same time, we need to support families and loved ones. Palliative care focuses on relieving suffering and to improve the quality of life, affirms life, sees death as a personal and natural process, appropriate early in course of an illness, patient and family preferences are always respected, and maybe, of course, combined with curative therapies or maybe the focus of care. It is an interdisciplinary care of the patient and family. Pain and symptom management may include disease-modifying treatments. It's all about psychological, social, and spiritual support. And of course, never forget that it's not only the patient, it's the family, and we have to consider the bereavement support after death for those that are left behind. Objectives is how and where we are dying, explain what is palliative care to our patients, setting the goals of care, delivery of palliative care, explain what is hospice, advanced care planning, and I want to explain a little bit about this because it's very important. Unfortunately, we are still, even in my country, we haven't progressed in planning how we'll proceed after we are with a serious illness. And this is a very important thing because we plan for future medical care in the event a patient is unable to make own decisions. And this should be updated regularly according to the course of the disease. What are the values and goals? Designate surrogate the decision maker in case we are not able to make our own decisions. Remember that this is a process and not an event, and it helps a lot because it reduces confusion and conflict. Ethical guides for treatment choices. All treatment decisions are made in context of person's values, diagnosis, prognosis, risks, and benefits of any treatment option, whether he chooses no resuscitation, no dialysis, uses of mechanical ventilation and antibiotics. This should be the patient's decision. Withholding and withdrawing a treatment are based on the same ethical principle of beneficence and consideration of risks benefits. Double effect, the intent of the treatment is to relieve X symptom. The dose of medicine did not kill the patient, it's the disease that killed the patient. The four topics, for an essential structure of an ethics case is the medical indications, which is diagnosis and therapeutic interventions to evaluate and treat. What are the patient's preferences, choices of patient or the person who makes the decisions about all treatment and all options? Quality of life, very important. And what is the quality of life after the treatment that the patient would like to have, and if this is possible. And contextual features identifies the familial, social, institutional, financial, and legal settings. Medical futility connotes inappropriate rationing, connotes worthy versus unworthy, and connotes decision based on financial only. And this is not beneficial care, and we have to change it on to beneficial care, which is based upon understanding context of this person's illnesses, experience, and values. Is based on knowledge of the diagnosis, prognosis, and risks or benefits of treatments, and uses ethical principle of justice as part of the decision. Physicians, nurses, and patients and families are all engaged in making these decisions. We have also, there are issues of dissatisfaction from nurse or physicians because the patient is not involved in treatment decisions, and this should change. Concerns about burdensome treatments, disagreements over withholding or withdrawing treatments. And there is also conflicts between nurses and volunteers when there is no good communication, confidentiality, conflict of interest, and compromised care. communication between all people involved, whether it's the staff or the patient and family, the physician with the patient and family, physician with the nurses or other health providers, physician to physician, sometimes language barriers, and inadequate discussion with the patient regarding treatment goals and expectations, degree of suffering, and measure of success. From all these there's an emerging ethical issues, and this is the resource allocation, not enough staff to provide palliative care, lack of bedside time, lack of time for quality communication, level of care, withholding, withdrawing treatments, and competencies in palliative care skills like communication skills, understanding of euthanasia, palliative rather than terminal sedation. And after many years, we decided that we should never call it terminal sedation, it's palliative sedation, because we are proceeding to control symptoms that we cannot control with any other medicine or any other way. That's the only time that we use palliative sedation. We should also consider cultural and religious issues related to dying persons, power issues, pain and symptom management, balance of patient choices, and family needs and choices. Mandating palliative care is very important at the end of life. Capacity determination, withdrawal and withholding of life-sustaining treatments, artificial nutrition and hydration, and blood transfusions. Any of these that are not necessary, they should never be applied at the end of life. The New York Palliative Care Information Act, which was effective since January 2011, requires healthcare practitioners caring for a patient with a terminal illness to offer information and counseling to patient or surrogate on available options for palliative and end-of-life care. Determining capacity is a specific issue. We have to understand the risks and benefits of prescription options, deliberate and evaluate in accord with personal values, and communicate his or her choice. Reassess for each decision. Capacity, have in mind, is different from competency. In absence of a healthcare proxy, permit surrogate to make healthcare decisions based on patients' no wishes, or if not known, in patients' best interest. The hierarchy in these decisions is the guardian, which could be a spouse or a partner, an adult child, a parent, a sibling, or a close friend. Limited treatment at the end of life. All patients have rights, even if incapacitated. They have the right to refuse any intervention. Withholding, withdrawing is not homicide or suicide. Orders to do are valid. Courts need to be involved most of the times, unfortunately. Withdrawal or withholding of life-sustaining treatments. Legally, there is no difference between withdrawal versus withholding of life-sustaining treatments. However, psychological, emotional, or religious constraints may exist for family. Legally required to do everything unfortunately, it's something that also exists in my world and in many parts of our world. We should consider if withdrawing or withholding if it constitutes euthanasia. This is, of course, not the case. And we are not killing the patient if we remove a ventilator. We just allow the course of the disease to take its natural course. And we have to explain and we have to change this attitude that the use of opioids to control symptoms at the end of life is a euthanasia. Opiophobia, it's a major issue all over the world, unfortunately. What is the patient's good? If medicine takes aim at death prevention than at health and relief of suffering, if it regards every death as premature, as a failure to today's medicine, but avoidable by tomorrow's, then it is tacitly asserting that its true goal is bodily immortality. Physicians should try to keep their eyes on the main business, restoring and correcting what can be corrected and restored, always acknowledging that death will and must come, that health is a mortal good, and that as embodied beings, we are fragile beings that must stop sooner or later, medicine or no medicine. Palliative care is guided by patients' goals. Advanced directives clarify patients' goals of care. Setting clear goals guides the direction and plan of care and minimizes ethical conflicts. Hospice is a way of delivering palliative care. Palliative care should be introduced early in the course of life-threatening illness and is compatible with curative care. Conclusion, palliative care is mandated in advanced stage incurable cancer and other terminal chronic illnesses. The different aspects of palliative care, such as pain and symptom control, psychosocial care, and end-of-life issues should be managed in an ethical manner. The cardinal ethical principles to be followed are autonomy, beneficence, non-maleficence, and justice. The palliative care experts and team members should carry out their responsibilities with honesty and dignity. Suffering due to unrelieved pain and unavailability of morphine are recognized as negligence of human rights. There are practical, ethical challenges which need to be resolved. Truth-telling, place of care, continuity of effective palliative care till the last days of life, confidentiality, unnecessary use of antibiotics, nutrition, blood transfusions, and advanced directives can be the key points which confront a palliative care team. The delivery of palliative care and medical ethics are complementary, and use of the two together maximizes the protection and satisfaction available to the vulnerable patient and family members. Palliative care is not about death, it's about life. I would like to thank you for paying attention, and I'm showing you two beautiful photos from the Troodos Mountains in Cyprus, which is in winter time when there is snow, because we do get snow also in Cyprus. Thank you very much for your attention.
All right. Thank you, Dr. Stylianides, for that wonderful and very informing presentation. I would now like to introduce Dr. Maisha Robinson. A little bit about Dr. Robinson. She is an assistant professor in the Department of Neurology at Mayo Clinic in Florida, with a joint appointment in the Department of Medicine. Upon joining the staff at the Mayo Clinic, she established the clinic's first neuro-palliative care program, and she currently serves as the division chair of palliative medicine Also, as the Associate Program Director for the Hospice and Palliative Medicine Fellowship, as well as the Chair of Ethics Subcommittee. Dr. Robinson earned her undergraduate degree from Princeton University and her medical degree from Tufts University School of Medicine, subsequently completing a residency in neurology at the Mayo Clinic in Minnesota, where she was appointed as the chief resident. She pursued a fellowship in hospice and palliative medicine at Memorial Sloan Kettering Cancer Center and returned to the Mayo Clinic in Florida for a neuro hospitalist fellowship. She was awarded a postdoctoral fellowship in health services and health policy research through the Robert Wood Johnson Foundation's Clinical Scholar Program at UCLA, during which she earned a Master's of Science degree in health policy and management and engaged in research focused on the intersection of neurology and palliative medicine. Dr. Robinson has spoken nationally and internationally on neuropalliative care. She edited a book titled Case Studies in Neuropalliative Care, and she is a member of the American Board of Internal Medicine, Hospice and Palliative Medicine Exam Question Approval Committee. She is also very active with the American Academy of Neurology, currently serving as the chief member of the Engagement Committee and an ex officio member of the Board of Directors. Welcome, Dr. Robinson.
Thank you so much for having me. I'm across the pond in Jacksonville, Florida, and really delighted to be here. So let me get my slides up here for us. Excellent. So this is going to be a brief talk on pain management in oncology. I have nothing to disclose. We're going to spend a little time talking about how to choose opioids. We'll look at some analgesic dosing principles, and I have a brief case that I'll share at the beginning just to get us started. We don't have a lot of time, so this is going to go fast. So Ms. Jones, a 54-year-old woman, she has a history of metastatic ovarian cancer. She's already undergone a total abdominal hysterectomy and bilateral salpingo oophorectomy. She's presenting with abdominal pain that she describes as constant, achy, located in the right upper quadrant, and it is significant, 8 out of 10. A CT scan of her abdomen and pelvis shows some omental studding and new liver metastases. So when I think about how to take a history for somebody that has pain, the first question is, where is it located? She's telling us it's in the right upper quadrant. The second question is, what is the description of the pain? She says achy pain, constant pain, and we can sort of try to determine, is this nociceptive pain or is it neuropathic pain? Most people know neuropathic pain, right? That's the burning, stabbing, shooting pain that people may describe. Everything else is nociceptive pain. There's nociceptive somatic pain affecting, for instance, muscles, tendons, limbs. Then there's nociceptive visceral pain, which affects the visceral organs. Then the question becomes, what is the profile of the pain? Is it changing? Is it constant? Is it breaking through some prescribed regimen that they're already on? Is it sort of intermittent, coming and going? Or in this case, she told us it is constant. What's the severity of the pain? Some people don't like this. We don't want to deal with the pain scale. But when you're taking care of a patient, their pain scale actually can be relatively valid because you're asking them to rate their pain sort of as time goes on. And so you can rate it based on how they're describing it. So she says 8 out of 10. And then if people are on other medications or other therapies, you can try to say, have those been beneficial or have they not? Another way to think about the assessment is a mnemonic that I learned in medical school, old cards. So when did the pain start? What was the onset? Where is it located? Is it localized? Is it widespread? What does it feel like? That's sort of the quality and intensity. We ask about the duration. Is it constant or incidental? What are the things that make it better or worse, right? So those are aggravating and relieving factors. How has it responded, I just mentioned, to any other regimens that you've tried? The other thing that I think is very important is, how is this pain interfering with your current daily life? What can't you do now because of the pain? Because I want to know that, because if I help the pain, they should be able to do some of those things that they can't do right now. And then what comes along with the pain? Are you tachycardic? Are you flushed? Are you nauseous with the pain? Are you having headaches? Are you depressed? What other signs and symptoms are going on when people are having the pain? I don't have to tell this group this, but I'll just mention it briefly, that we know pain can negatively impact people's function completely. The way they move, the way they think, the way they concentrate, the way they're able to eat and sleep, and it can affect their mood. And this can result in the way they show up in life, the way they engage with other people, the way that they care for other people and care for themselves. So we really have to focus on trying to alleviate pain, particularly in our patients that have cancer. So back to our lady that we discussed, I mentioned that she has nociceptive visceral pain because it's in the abdominal area. And so we are now going to try to figure out, how can we help her? So how do we choose our pain medications? Well, the World Health Organization has this ladder that they've organized with regard to relative medication strength. So the first step on the ladder, we think about weak pain medications, weak analgesics. Many people think about aspirins or paracetamol, also known as acetaminophen, the nonsteroidal anti-inflammatory medications, and then plus or minus adjuvants. Adjuvant medications tend to be medicines that will work for pain, but weren't initially designed for pain. So things like anti-seizure medicines like gabapentin is a common one that people may use, or steroids, which can be used for pain, although those medicines weren't initially designed to manage pain. The second step on the ladder would be moderate medications with regard to strength, codeine, tramadol. And then we see these combination medicines. So the paracetamol and codeine, or paracetamol and tramadol, or paracetamol and hydrocodone, paracetamol, oxycodone, and then we can't forget our adjuvants. And although it's not on this ladder, I will add that you can also continue to think about adding aspirin in this situation, or NSAIDs as well, as these medicines all work in a bit of a different way. And then we get to the third step on the ladder. These tend to be our stronger opioids: morphine, oxycodone, hydromorphone, fentanyl, methadone. And then also we remember our adjuvants, and I'll add again, aspirin and NSAIDs can be added here as well. So where do you start on this ladder? Well, I mentioned that they were grouped based on relative strengths. Our patient told us her pain was 8 out of 10, and so she has severe pain. You'll see for mild pain, we tend to think about 1 to 3 out of 10. For moderate pain, we tend to think of 4 to 6 out of 10 in terms of severity of pain, and Our Lady is within the 7 to 10. And I'll say plus, because some people would say, my pain is 15 out of 10, but this lady said 8 out of 10, so she has severe pain. Anytime we're thinking about pain medicines, we always have to remember the potential adverse effects or side effects for these medicines. The common ones for opioids, at least, tend to be constipation, nausea, vomiting, and sedation. But there are others. Some people may complain of itching or dry mouth, or sort of seeing bugs crawling around the room. Sometimes I'll ask that and say, Dr. Robinson, what do you think? You think I've gone crazy? But I throw that in because every once in a while, somebody will say, yes, I have been seeing bugs around the room. And I say, well, that's your pain medication. If it's bothersome to them, we may have to rotate medicines. But some people will say, I know they're not real, and I'm okay now knowing that it's just a side effect of medication. But there are, some other ones, urinary retention as well, that we may ask about, confusion too. So when we think about dosing principles, let's start here. First order kinetics. These are medicines that have a predictable response to dosing. So you give the medicine. When the concentration increases, pain gets better. As the concentration decreases, people tend to tell you the pain returns. And so here is the schematic for it. You take the pill, let's say, pain improves as the medicine goes out of the system, the pain may come back. And so this is time, you see, on the x-axis, and the concentration of the medicine on the y-axis. So when the concentration is high, pain is better. As the concentration decreases, pain comes back. First order kinetics, predictable response. This is most analgesics except methadone. These are often the medicines we use in palliative care. We just heard an excellent talk a second ago about palliative care in general. And one of the things that I mentioned was the need to provide adequate symptom and pain relief. And so when we're thinking about medicines in palliative care, most of these medicines will follow first order kinetics. And there's certainly a risk of side effects. So once we give a medicine, we'll monitor the response. If people are needing extra medicine, so beyond their usual regimen, we call it a breakthrough pain, and they need a breakthrough dose of medicine. We offer that every Tmax as needed. So you might be saying, okay, Dr. Robinson, what's the Tmax? Well, I'm glad you asked. I'm going to introduce two concepts here, a Cmax and a Tmax. The first is Cmax. So Cmax really means the C is concentration, max is maximum. So the analgesia is greatest at the time of maximum concentration. So when the highest amount of medicines in the system, the patient is going to have the best pain relief. You can probably imagine that the time that it takes to get to that maximum concentration is the Tmax, right? So Cmax is maximum concentration. Tmax is time to get to that maximum concentration. So Tmax, you'll see right here, is aligned with Cmax. So we're going to spend most of our time talking about morphine today. So I'll illustrate here with morphine. Depending on the route that you give it, the Tmax will vary. So oral morphine, the Tmax will be about 60 minutes. It takes about 60 minutes to reach the maximum plasma concentration. If you give it subcutaneously, intramuscular, it'll take about 30 minutes. If you give it IV, 15 minutes. So certainly IV is the fastest, but you'll also see the concentration drops the fastest, right? So it gets into the system fast, but it doesn't stay. The oral takes longer to get in the system, but it stays longer. So principle one, I mentioned this briefly a second ago, but now that we've introduced these new concepts, I'm going to say it again. For extra or breakthrough pain, so pain that's breaking through somebody's usual pain regimen, you offer an extra dose every Tmax as needed. The patient can say, no, I don't need it, but it's an as needed dose that should be available. The other thing I want to emphasize is that for somebody that is opioid naive, never been on pain medicines before, opioids before, we use these short-acting medicines that have a predictable response. We don't use extended release opioids. So, breakthrough medicines are given in every Tmax as needed. So morphine, we talked about, oral morphine or rectal morphine, it takes about 1 hour to reach the Tmax as the time at the maximum plasma concentration. So after 1 hour, a patient would have an available dose of morphine that is for the breakthrough pain. And they can say no. For constant pain, we dose it every half-life routinely. So let me talk about half-life now. So half-life is the time it takes for the body to eliminate half the dose. So if you give a 10 milligram dose of morphine, in order for you to get to 5 milligram when it remains, half of the dose eliminated, right? And so you're trying to see how long does it take for half of the dose to be out of the system, eliminated from the body. So for morphine, all routes, it's about 4 hours. Half of the dose is gone in 4 hours. So 5 milligrams would remain. For constant pain, we give medicine every half-life to achieve steady state. So if we dose oral morphine, which has a half-life of 4 hours, you'll see that it takes 5 half-lives to achieve steady state. So the first dose is given at 4 hours, you give another dose. At 4 hours, you give another dose. And you keep going until you have 100% of the medication available. This matters because we want to find the sweet spot where a patient is not having too much of the medicine where they're getting a lot of side effects. We're trying to find the sweet spot where they're not having too little of the medicine, where they're having terrible pain. But we want to have enough medicine constantly in the system so that pain is well controlled. And so that is the space between too high of a concentration, too low of a concentration. And so that's sort of the steady state. There are some peaks in there and some troughs in there, but the pain is reasonably well controlled. So although I'm going to focus mostly on morphine, I did want to provide a few starting doses for some other medicines that you may want to use. The first would be paracetamol or acetaminophen. You start at 325 milligrams every 4 hours. The maximum would be 650 milligrams every 4 hours, just thinking about liver protection. And the steady state for this is also 20 hours, so 5 half-lives. Ibuprofen, 200 milligrams is a good starting dose every 4 hours. The maximum is about 600 milligrams every 4 hours. Again, steady state is achieved in about 20 hours. Back to the morphine immediate release. The dose could be variable, but as I mentioned, you can give it every 4 hours. Tmax is 1 hour. The half-life is 4 hours, and steady state is about 20 hours. Now, tramadol is a little different. Starting dose would be about 50 milligrams every 6 hours. The maximum is 100 milligrams every 6 hours. And so the Tmax for tramadol is 2 hours, and the half-life is 7 hours, and it takes 30 hours to reach steady state in this situation. Okay, so let's talk a little bit about what we're going to do for this patient with regard to a morphine dose. So she told us her pain was 8 out of 10. She has not previously been on analgesics, which is opioid naive, meaning we want to start with short-acting medicines. We can think about morphine 10 milligrams or 15 milligrams, and we will dose it every 1 hour as needed. And so if they're a patient that you're taking care of is maybe elderly or frail, you could consider reducing the dose 25 to 50% or so, particularly if you're concerned about the potential effects. So in this type of situation, what as needed dose could be used? We talked about for extra breakthrough pain, we can provide an extra dose, which is usually 10 to 20% of the total dose that they've gotten in 24 hours. Okay, or you can add up the 24-hour dose and divide by 6. You'll get a dose that is similar to the 10 to 20% of the total 24-hour dose. And so you can approach it either way. And you offer that every Tmax as needed. And of course, the patient can refuse. And for morphine, that's going to be every 60 minutes. For this lady, we're going to give her a routine dose of morphine immediate release. That's the IR, 15 milligrams every 4 hours. So her total dose in 24 hours would be 90 milligrams because she's getting 6 doses within 24 hours. So if I said 10 to 20% of that for her as needed dose, I could get somewhere between 9 and 18 milligrams because morphine comes in 15 milligram tabs or 30 milligram tabs. We say her as needed dose is 15 milligrams. Okay, so we added up her 24-hour dose, which is 90 milligrams. We get 10 to 20% of that to figure out her as needed dose, which would give us somewhere between 9 milligrams and 18 milligrams. And because morphine comes in 15 milligram tabs, she'll get 15 milligrams as her as needed dose. So before we give the as needed dose, we want to make sure we recorded the dose that we've given. We ask about pain severity, and we ask about any adverse effects. How are you feeling with it? Are you confused, too sleepy? Are you constipated? Are you seeing any bugs crawling around? Are you nauseous? And then making sure that that is documented. So let's play around with this a little bit. This is just a little clock that we're going to provide some dosing around the clock for. So if we start her medications at 10 a.m., we've decided we're going to start at 15 milligrams for her routine dose, and she can get it every 4 hours. And that would be scheduled because she has constant pain. So scheduling 15 milligrams of morphine every 4 hours. So she would get it at 10 a.m., and we would anticipate that she would get it again in 4 hours, which would be 2 p.m. So we'll start at 10. And then we say, do you have pain in 1 hour, right? Because that is the Tmax. So do you have pain in 1 hour, 11 a.m.? And we offer her the breakthrough dose that we calculated as 15 milligrams of morphine. So there's an option for her to take an at 12 o'clock. There's another option to take an as needed dose of 15 milligrams. At 1 p.m., there's an option 1 hour later to take another 15 milligram dose. I think you're following this now. And then if we say at 15 milligrams is her constant dose every 4 hours, and then we've given her 15 milligrams as the breakthrough dose as needed. If she's still in pain at 2 p.m., how much can she have? And I mentioned to you that at 2 p.m., that's her scheduled dose. But don't forget, she can still get the as needed 1 hour dose. So potentially, if she were still in pain, she could have 30 milligrams. The 15 milligram standing dose is not negotiable. She should take that. But if she says, my pain's kind of under control, she doesn't have to take the as needed 15 milligrams. So I'm hoping everybody's following this. So we started her at 10 a.m. with a 15 milligram scheduled dose. Because she has constant pain, we will schedule 15 milligrams of morphine every 4 hours. If her pain breaks through, so remember that graph that showed she had pain and there's a breakthrough. If her pain breaks through this 15 milligram regimen every 4 hours, she has an option to have an as needed breakthrough dose every 1 hour, because that's our Tmax. That's when the morphine is reaching its maximum concentration. And that's when we give our breakthrough dose. So you'll see on this clock, every 1 hour after 10 a.m., she has the option of getting an additional 15 milligrams. And we found that additional 15 milligrams by calculating her 24-hour dose of the scheduled morphine. 15 milligrams every 4 hours. So 15 times 6 times a day is 90 milligrams. Taking 10 to 20% of that is 9 to 18 milligrams. Morphine comes in 15 milligram tabs. That's how we got our 15 milligram breakthrough dose. So she has the option of that 15 milligram breakthrough dose every hour after we start the medication, including on the hour when she gets her scheduled medications. So this is sort of an example of what a pain diary might look like at 10 a.m. She told us her pain was 8 out of 10. We gave her the 15 milligrams scheduled. At 11 a.m., her pain is a little bit better. It's 6, but it's still there. So we gave her the PRN 15 milligrams. At noon, she still has pain. She got the PRN 15 milligrams. At 1 p.m., pain is still 5 out of 10. She got the 15 milligram as needed. At 2 p.m., her pain is 6, and she wanted the as needed medicine. And then we also gave her scheduled dose of medication. So initial dosing, we dose based on the pharmacokinetics properties that we discussed for the first order kinetics. We try to figure out, has it been helpful for her? And we think about the safety of the medicine. Any opioid calls for us to safely prescribe it. It doesn't matter about the dose. A low dose could also be unsafe in some people. So we want to make sure that we're being very, very careful as we're prescribing opioids in general. So we think about the efficacy, is it effective, and the safety of the medications. And then we also want to anticipate common side effects. Most commonly constipation or nausea, but I sort of showed the entire list of potential adverse effects. So for some people, like for this lady, we'll have to think about, what are we going to do long-term for her if she's needing really medicine around the clock? So I mentioned that people are opioid naive, we would only start with short-acting opioids. Once people have taken short-acting opioids for a prolonged period of time, they're no longer opioid naive, right? They've become tolerant of opioids, so they're opioid tolerant. Then we can think about adding an extended release medication like morphine extended release. So morphine IR was morphine immediate release that we were just talking about. Morphine ER, or morphine extended release, is provided in a capsule form that has a slow release of medicine over time. And you start the dose based on what the demonstrated need would be. So we could calculate her 24-hour use of morphine. So we know we were already giving her 15 milligrams of morphine every 4 hours, and so that's 90 milligrams. But then we have to add up all the as needed doses of 15 milligram that she got as well. And that would give us our total 24-hour dose. And then we can use that to determine how much should we automatically give her every 12 hours. Which is a scheduled amount in the morning, a scheduled amount in the evening. Some people would take 50% of that total dose and break it in half and just give it to her automatically in the morning and in the afternoon. Others would take more, 80% of it. So some of this has to do with your comfort level. The Cmax for these extended release medications is about 2 to 3 hours for morphine. We dose it every 12 hours, and it takes about 60 hours to reach steady state. So you see, we're dealing with a little bit of prolonged time to get the maximum concentration into the system because it's a time release formula, and it takes longer to achieve steady state. So the last thing I'll just mention is that we want to anticipate side effects, and you want to prescribe for that. So there are many medicines you can give for nausea, some that are easy to get, maybe haloperidol. We think about constipation as well. Senna, 1 tab twice a day to start. Think about other medications, not only for Senna, but osmotic as well. Laxatives like polyethylene glycol can be used, or lactulose can be used also for that. So this was a fast presentation, but I hope you got a little bit of a primer to how we think about medications, particularly for pain in patients with cancer. We're thinking about some of the stronger opioids for many of these patients, about how to start finding the medication to use, thinking about some of the pharmacokinetics of the medicine, and how we continue to titrate. So I borrowed some of these slides with permission from the Palliative Care Interdisciplinary Curriculum, so I want to thank them for the opportunity to utilize some of these slides and to provide some acknowledgments here as well. Thank you so much for the opportunity. I think we'll have a moment at the end for questions.
Thank you very much, Dr. Robinson, for a very well delivered lecture, very informative and very educative. Thank you very much for simplifying a very difficult subject to the understanding of everyone. Please look in the Q&A. There's probably 1 or 2 questions that can be addressed while we continue. For the benefit of those who were not here when I introduced our keynote address speaker, he's going to be giving the next lecture titled Controlling Gastrointestinal Symptoms in Cancer Patients. He's no less a person than Dr. Kyriakos Stylianidis. Dr. Stylianidis has been practicing palliative care in Cyprus since the year 2006. He graduated from Ovidius Medical University of Constanta in Romania in 1999. From 2000 to 2001, he worked as a junior doctor in the Bank of Cyprus Oncology Center in Nicosia. And during his time there, he did several courses in palliative care, including Essentials in Palliative Care from Prince Alice Hospice, Communication Skills course, and 2 months fellowship in San Diego Hospice. From 2015 to 2017, he studied for a postgraduate degree in hospital management at the Open University of Cyprus, and in November 2017 was awarded the bachelor degree of Health Units Management. Since November 2018, Dr. Stylianidis has been employed at the Pan-Cyprian Association of Cancer Patients and Friends as the medical director. In March 2019, he spent a month in Ohio State, where he was trained in palliative care for children. And since September 2022, Eden Hospice in Lannis and St. Michael's Hospice in Paphos. started, he has been providing services for palliative care patients through Cyprus National Health System. And he directs both hospices. He lectures sixth-year medical students in palliative care at the Cyprus Medical School. He participates with ASCO as a facilitator in education for palliative care around the world. He has participated in several master classes for palliative care, both in organizing the master class and as a key presenter and facilitator. Dr. Stylianides played an important role in establishing legislation for palliative care in the island of Cyprus. He convinced the Ministry of Health that palliative care should be part of the national health system, and it should be offered to both adults and children from the beginning of their diagnosis. His main goal was to make palliative care available for all the patients that needed it all over Cyprus. Dr. Stylianides is the first doctor registered as a palliative care physician in Cyprus National Health System. Please join me in welcoming Dr. Kyriakos Stylianides to present to us his lecture on controlling gastrointestinal symptoms in cancer patients. Welcome.
Thank you again, Kenneth. Such a common problem, the gastrointestinal symptoms in cancer patients, and it's a problem that we have to face very often. And I hope with this presentation, it will help to control as much as possible the symptoms of our patients. So first of all, I would like to thank you, the PCIC, and Dr. Frank Ferris for providing the slides for this presentation. And I will start with nausea and vomiting, which is the most common and quite often difficult to control.
But I could not have imagined the depths of humiliation. Oh. God, please. Steady. Steady. Oh God. What's left? I haven't eaten in 2 days. What's left to puke? You may remark that my vocabulary has taken a turn for the Anglo-Saxon. God, I'm going to barf my brains out.
How does it feel to spend the whole day like this? It must be awful. The objective is to describe the pathophysiology of nausea and vomiting. We have to develop a rational approach to management, and of course, practice makes perfect. Why do we care about nausea and vomiting? It's a very common symptom with cancer patients. It causes distress both to patients and their families, and of course to health care providers. And it affects the quality of our life. What is the assessment? Location, description, how does it change over time, the severity, and of course, the effect of medications and other therapies. And how do we manage it? We identify the cause or the pathway, and we either treat the cause or we block the pathway. What are the main causes? We have divided the main causes of nausea and vomiting into three categories: above the neck, below the neck, and the systemic. Where above the neck is a mass and metastasis, the meningeal irritation, migraine and other headaches, and movement. Below the neck, again, it's a metastasis or a mass, motility, mucosal irritation, mechanical obstruction, myocardial infarction, and maternity. And systemic is mentation, anxiety, medications that they cause nausea, vomiting, microbes, infections, and metabolic. And that's another acronym of vomiting, where V stands for vertigo vestibular, O for obstruction, constipation, M for motility dysfunction, I for inflammation of gut, T for toxins, I for intracranial masses, N for nerves and anxiety, and G for gums, mouth, and oropharynx. What are the pathways? Two common pathways. One is the chemoreceptor trigger zone that is triggered, and then is the vomiting center that is triggered. And the stimulating pathways are the chemoreceptor trigger zone, the cortex, the vestibular, and the peripheral, which is the gastrointestinal tract. The neuroreceptors involved in triggering nausea and vomiting are neurokinin, serotonin, dopamine, acetylcholine, histamine, and GABA. And this is a nice diagram where each chemoreceptor trigger zone is each neurotransmitter is involved in which area. And we need a rational approach to management. As we said, we have to identify the cause and the pathway. We dose around the clock. We titrate to effect. We consider side effects of our treatment. And if first agent is ineffective, add another with a different mechanism of action. And we have to consider also non-pharmacological management, like cognitive behavioral therapy, acupuncture, relaxation, and hypnosis. Avoid strong smells, eat small and frequent meals, and supplements like ginger. Medication classes that are used are the dopamine antagonists, 5-HT3 antagonists, NK antagonists, prokinetics, antihistamine, anticholinergic, steroids, and benzodiazepines. And of course, practice always makes perfect. Here, I providing you with 3 slides, 4, which they summarize the nausea management. First, this is the causes and what kind of medication we can use to treat the cause of nausea and vomiting, which are also available to you, and you can use them. And these are the usual doses of the different medicine that we use in order to control nausea and vomiting. So as we said, it's a rational approach to manage nausea and vomiting. understand and target the cause and/or pathway. Let's move to constipation and malignant bowel obstruction, which is also a very common problem in cancer patients. And unfortunately, it's usually severe with a lot of side effects. Is usually for patients with advanced illness. We need to describe the causes of constipation, compare and control laxatives used for the treatment of constipation, and outline an approach to manage constipation. When we have a normal bowel movement, it means that there is a normal lubrication and motility. So solid waste and water content are in a balance, and then this can be excreted normally through the intestine. And constipation, when it occurs, it's a persistent, difficult, infrequent, or seemingly incomplete defecation. And it's also, as I said, a very common symptom we see in our patients, and it causes a lot of problems, and it destroys the quality of their life. It leads to decline functional status, decline nutritional intake and socialization, poor quality of life, and of course it hurts. There are many causes of constipation, from surgery to trauma, peritonitis, pregnancy, diet low in fiber, dehydration, psychogenic, painful fissures or hemorrhoids, and mechanical obstruction. The assessment of for constipation, we need to get a good history, the quality of bowel movements, any other associated symptoms, any prior surgeries, medications used, and advanced illnesses like heart failure and of course cancer. Examine the patient, very important, and consider testing for electrolyte abnormalities and imaging. Management of constipation should be done as soon as possible. Prevention is the best treatment as always. So we have to start by preventing constipation. In order to prevent it, we need to assess for the cause, treat the underlying cause, and then treat the symptom. Medications that very often cause constipation, first of all, analgesics and opioids. Our colleague before, she mentioned that very often, almost always, opioids, they cause constipation. And as we say, the same hand who prescribed opioids needs to prescribe laxatives at the same time. And of course, other medicine are causing constipations like anticholinergics, calcium channel antagonists, diuretics, iron preparations, polystyrene sodium sulfonate, barium sulfate, antacids, clonidine, ganglionic blockers, muscle blockers, and ondansetron. Goals for management, often resetting expectations, balance stool frequency and consistency with comfort and always dignity. Incorporate individual preferences. It's all about the patient. Each patient has its own needs. Contributors to constipation. If any of these solid waste, lubrication, water content, or motility, it's not balanced, we'll get constipation. So we need, for normal bowel movement, we need to balance these four. There are non-pharmacological treatments for constipation, like fiber-rich foods, increased physical activity, increased fluid intake, and ritualized bowel habits. And of course, we can use pharmacologic treatments like bulb-forming laxatives, surfactants that are actually softeners, osmotic agents, stimulant laxatives, and opioid-induced constipation agents that they reverse the opioid cause of constipation. Here are some medicine used in order to control constipation. And it's important to see where we are targeting and never be afraid to use an enema if all the others, they will not work. The sites of action of common anti-constipation agents. So for the small bowel, it's castor oil, polyethylene, glycol, lubiprostone, and linaclotide. And for the colon, bisacodyl, senna, lactulose, and hyperosmolar salts. We use a stepwise approach to managing constipation. Step 1, provide patient education, increase fiber and fluid intake, encourage mobility. Step 2, modify risk factors, reduce or eliminate any constipating medications. And treatment for mild symptoms, stop ineffective treatment, start polyethylene glycol, and start senna orally. The step 2 is increase the dose until resolution or maximum dose is achieved. And if we have loose stools, we decrease the dose by 50%. For severe refractory symptoms, we might need to do an abdominal X-ray or CT scan, or even a colonoscopy and anorectal manometry. We use stronger agents like magnesium citrate and bisacodyl. And step 3, if none of the first 2 steps are working, we can use enemas. In case of opioid-induced constipation, opioids, as you know, they attach to mu receptors in the small intestine. This inhibits the release of neurotransmitters such as acetylcholine and interrupts normal peristalsis. This decreases the intestinal secretions, and there is an increase of fluid and electrolyte absorption, which in turn they make the stools hard and nowhere to defecate. And of course, if which they do cause increased anosphincter tone, you don't feel that you want to go to defecate. And constipation, it's one of the common causes of delirium, which is another symptom very difficult to manage. Prevention for opioid-induced constipation is very important, as we said. All patients should be prescribed a laxative like senna that they are on opioids. It's not correct to rotate the opioid because of constipation, because they will also cause constipation. So the first line is stimulant laxatives, but if they are not working, we can use peripheral opioid mu receptor antagonists like methyl naltrexone and naloxegol, very expensive medicine, not always available. That's why it's very important to control constipation, to prevent constipation induced by opioid use. Special considerations for palliative patients if there is an obstructive mass or carcinomatosis, which can be the end of the cause of constipation. Ileus, very common in our patients with cancer. And we have to consider if they are end of life and how we will treat those patients. And we have to consider if they are neutropenic. Often our patients, they are on antineoplastic treatment with chemotherapy and they are neutropenic. And also consider overflow incontinence, because they might have an obstruction, they get diarrhea, but this is diarrhea, as we call it, an overflow diarrhea, and the intestine is still obstructed. Docusate is rarely sufficient and often unnecessary. Think mush and push. So we want to make them, to soften them and make the intestine to increase the peristalsis in order to for our patient to defecate. Maximize adjuvant pain medication, and we should always aggressively manage constipation. I'm providing you here an assessment of constipation and management of constipation with all the medicine and the causes of constipation. As we said, a rational approach to managing constipation, understand and choose medication based on the pathophysiology. And the last topic, it's bowel obstruction, one of the most severe symptom that we need to address for patients, especially with advanced metastatic cancer. Very common, and a symptom that causes a lot of dysfunction to the patient. The background, so is usually caused by ineffective motility or occlusion of the lumen, common affiliated cancers, large or small bowel. It can be partial or complete obstruction, and its relevance to palliative care. Because life expectancy in inoperable, if we can operate, is 4 to 6 months, but if you cannot operate, it's 4 to 6 weeks. This is usually the case. We have a patient with ovarian cancer with a continuous and colicky abdominal pain, abdominal distension, no bowel movement for 7 days, nausea and vomiting. It's acute, large volume with undigested food, and is usually there is relief after emesis. The treatment, if we can reverse the, it means it's a good prognosis. We try if we can non-surgical for partial or complete obstruction. The management algorithm, if we have a malignant bowel obstruction, if there is too much vomiting and if the patient can tolerate, we have to use an NG tube and haloperidol. And then the plan is according to the prognosis of each patient. If it's years, then yes, he needs surgery and support with maybe parenteral nutrition. But if it's days to a few weeks, then we take supportive measures using pharmacology and a venting G tube to relieve the symptoms if we fail to manage the obstruction with medical management. So that the patient can have some taste of food. Stents are used, surgery, as we said, and some decompressive interventions. Always it has to do with life expectation of each patient. So it's very important to assess the patient and to address the prognosis of our patient. Unfortunately, when we have a complete bowel obstruction, it's a vicious circle where this bowel distension, bowel contractions are increased, there is continuous abdominal pain, there is damage of intestinal epithelium and hypertensive state in the lumen. There is an inflammatory response with production of prostaglandins and secretagogues, VIPs, and nociceptive mediators, which leads to hyperemia and edema in the intestinal wall. This increases in the bowel secretion of water, sodium, and chloride, which can lead to nausea and vomiting, and increases the gut epithelial area, surface area, increase more the luminal contents, and then this is like a vicious circle, which is getting worse and worse until we can find a way to resolve it. And we can consider a progenetic only if there is a partial obstruction, because if there is a complete obstruction, nothing can help. And in this case, if there is a complete obstruction, we have to consider an anti-secretory. And if there is nausea and vomiting, an antiemetic. Steroids are helping for the inflammation. And of course, for the pain, we use analgesics. We have to, if there is a partial malignant bowel obstruction, we have to try and get the bowels moving. We don't need to use an anti-secretory. We consider a laxative, a question for the progenetic, if it's not a complete obstruction, dexamethasone for the inflammation. Opioids can be used if we cannot control the pain otherwise. The treatment goal, if we have a complete bowel obstruction, is where the gut shut down completely. At this point, we need to use, in addition to dexamethasone and opioids, an anti-secretory, and for nausea, we use haloperidol. And as I said, we can consider using a venticastrostomy. This is the usual case, young female with cervical cancer and peritoneal carcinomatosis. It's a complete bowel obstruction. So she has nausea, vomiting, and pain. And we can administer all this medication together, like metoclopramide, dexamethasone, haloperidol, and octreotide, together with hydration. And in palliative care, we do not use IV, we use subcutaneously. Most of these patients, they do not have IV access. They have lost a lot of weight, they are dehydrated. So we use subcutaneous access, and we can administer all this medicine over 24 hours, because we always act according to the pharmacokinetics, and they need a continuous infusion of this medicine to control their symptoms. And as I said, we always consider about pain, and the use of opioids and anticholinergics can help to relieve the pain. These are some of the doses that we can use for the malignant bowel obstruction. In summary, a rational approach to managing constipation and malignant bowel obstruction, we have to understand and choose medication based on the pathophysiology. We don't want to see these pictures in front of us. And as Gandhi said, you need to be the change you want to see in the world. So act fast, relieve the symptoms, and never allow our patients to suffer alone. Thank you very much for your attention. This was the end of my presentation.
Dick, please go ahead.
Are you are you next?
Okay, thank you very much, Dr. Kyriakos, for your beautiful presentation. Very informative. I think Dick will take us through the Q&A session on this. Dick, please.
The Q&A is open for anybody has questions for both of our presenters. That is open, so if you want to ask some questions.
Or make comments.
Or make comments.
Including the panelists.
I do have one question for Dr. Stylianides. Where does euthanasia, where is that in palliative care? And I know there was a lot of discussions in the states here, different states were looking at it. And I think some states, I think Oregon did pass it a while ago, but where is that in the realm of palliative care, and where do you see it going?
So what we actually say, palliative care physicians, if we provide good palliative care, and if palliative care is available to patients, to all patients, I believe, and this is also my opinion, that less people will be asking for euthanasia. It's a common topic also in my country. And unfortunately, people confuse palliative care that it's a way of euthanasia because we provide with opioids, but our patients. But what we do is we provide good symptom control. I think there are a lot of discussions also in Europe about euthanasia. There are, I'm not sure, but I think there are some countries which they allow it, and not exactly euthanasia, but assisted suicide, if I'm not mistaken. This is what is allowed. It's very few, though, European countries that they allow it. I do not agree. In my opinion, we should make more effort in providing better quality of life to our patients. And if we can do that, then there will be much less people asking for it, for euthanasia.
We do have another question for you. How likely is red blood cell transfusion to make patients feel better or reduce anxiety? Post-transfusion RBC documentation is often poor, but physicians occasionally document that the patient feels better after blood transfusion. Do they actually feel better?
No. No. And from my experience over the 20 years, they do not feel better. And sometimes what does blood transfusion does usually is that it's prolonging their suffering, because it's a natural process of having low hemoglobin in advanced cancer. Okay, and they do not suffer because of low hemoglobin. There is no suffering because you have low hemoglobin. When your hemoglobin is lower, yes, you are less active. But anyway, when you have advanced cancer, you cannot be active because you are very weak to move. You are having difficulty in breathing. You get easily tired. So it doesn't improve the quality of your life. It actually sustains an already bad quality of life, and it prolongs a natural process, because we believe that death is a natural process, that it will happen sooner or later. And by giving blood transfusion, you just prolong the suffering of the patient.
There is another question for you. Most elderly females generally tend to have constipation. Some have been abusing Dopalax tabs. How can we wean them off this drug abuse and introduce them to better laxatives?
So it's another common symptom for elderly patients, because they are less active. They do not drink a lot of water. So prevention of constipation, it's mandatory for everybody, even of course for elderly people. So what we need to do is educate what they need to do before they come to have constipation. And even if it comes to a point that they end up having constipation, we can try with natural process, like what kind of food they can have, and what high fiber that helps them defecate much easier. And it's all about education. It's all about education and of course prevention.
If anybody has any questions, you can put them in the question box and we'll read them off. I know some people are having trouble with that. So.
If Maisha has additional comments on the previous questions, she could add.
No, Dr. Robinson said she's answered a number of questions in the Q&A. All right. Here's how often should advanced care planning be updated? In Canada, an advanced director was disqualified because it was too old.
So it's very important, as we said, to have an advanced directive plan. The plan should be updated whenever there is change in the health status of the patient. So this it is not a time it depends on the health status of the patient, and that's how we decide when to change the advanced directive plan.
Any other questions? Okay. We're going to go to the videos.
All right, thank you very much. Thank you very much for the very interesting and interactive session we have had. That brings us to the end of the Q&A. And right away, we're going to the session on short videos. And I want to call on Miguel to help us with the short videos. Miguel, are you there? So I'd like you to play a video on bloodless medicine and surgery, what you need to know. Can we have that video, please?
I think he's trying to get it started. Oh, okay. It looks like he doesn't have it. Please mention the name of the video again.
What you need to know, bloodless medicine and surgery.
Okay, 1 second. Oh, I'm sorry. I need to stop this. I'll do it again. Chest sound, yep.
Providing bloodless care to patients is simply providing medical care without giving patients blood donated by another person. The way we do this is to conserve blood by reducing or eliminating bleeding, by stimulating the body to make its own blood cells at an accelerated rate, and also by recycling blood that patients lose during surgery and giving them back their own blood. Well, there are several reasons why patients may choose a bloodless approach to their surgery. Historically, patients have elected to avoid transfusion because of religious reasons, but also some patients just simply wish to avoid the risk or the side effects of transfusion. For example, we know that patients treated with the bloodless methods have a shorter length of stay, decreased incidence of hospital-acquired infections, and also less chance of an allergic reaction or even receiving the wrong unit of blood, which still occurs. The first thing we do is we diagnose or treat anemia prior to surgery, so patients come to the operating room with enough red blood cells so they can tolerate any blood loss. During surgery, you can avoid hypothermia or hypertension, both of which can increase bleeding. And then we can collect and recycle the blood they lose using the cell saver and give them back their own blood during surgery. We can also use what we call ANH, acute normal volemic hemodilution, which is where we bank the patient's own blood at the beginning of the case and give it back to them at the end of the case. There's one more technique. There's new versions of electrocautery that have come out recently that can dramatically decrease bleeding during orthopedic cases and during spine surgery, for example. Virtually 99% of all the procedures we do can be performed without transfusion. For example, we've done some really big surgeries like a Whipple for pancreatic cancer. We've done many of those without transfusions. We've done open heart surgeries, even revision open heart surgeries for valve replacements and bypass surgery without blood. And recently, we even did a 6-kilogram baby, that's about a 14-pound baby, who had open heart surgery for tetralogy of Fallot, requiring cardiopulmonary bypass without a transfusion. We believe that we offer more different types of specialty care than any other hospital in the country that has a bloodless program. Plus, our program blends seamlessly into the care plan that's offered by all varieties of specialties within the hospital. Surgery itself is becoming less and less invasive. For example, the laparoscopic and robotic approach to different surgeries have dramatically decreased the amount of blood that patients lose and the amount of transfusions they require. Also, we're giving new intravenous medications like iron, or we're even giving erythropoietin, which is one of the medications that the professional cyclists use to blood dope. Only now we're giving it legally to our patients to build their blood counts prior to surgery so they don't require a transfusion.
Okay, the next video is how it works, bloodless medicine and surgery, an alternative to blood transfusion. And we have the next video, please.
Every year in the U.S., patients receive 21 blood transfusions. What if there was a solution? Every year in the U.S., patients receive 21 million blood transfusions. What if there was a better solution with significantly improved outcomes?
So nearly every surgical procedure involves some degree of blood loss. And traditionally, we give patients blood from the blood bank. However, another option exists, which is called bloodless medicine and surgery. We use alternatives to transfusion.
Techniques performed before, during, and after surgery result in minimized blood loss, faster recovery, fewer infections, and quicker discharge. Bloodless medicine eliminates the need for blood transfusion, thus avoiding the dangers of allergic reaction, contamination, and the possibility of receiving the wrong blood type. Before surgery, Medication and nutritional supplements increase hemoglobin levels, which help your body handle blood loss during surgery. A process called hemodilution temporarily replaces a portion of the patient's blood with fluids, lessening the impact of blood loss during surgery. Tools and techniques used during surgery include anesthesia processes to safely lower blood pressure. Harmonic scalpels clot the blood while cutting the tissue. Cell salvage machines collect lost blood, wash it, and return it to the patient. Hemoglobin monitors reduce the need to collect blood samples to be sent to the lab. After surgery, medications and techniques can minimize bleeding and improve oxygen in the blood. Often after surgery, blood must be drawn to run follow-up testing in the lab. Microsampling requires 1/10 the amount of blood traditionally drawn, reducing the amount of blood patients lose by almost 90%. At Johns Hopkins, our team of highly trained experts have been providing patients alternatives and peace of mind for years.
Right. So we're going to have the next video titled Building Your Hemoglobin Level Without Blood. Next video, please. Building your hemoglobin level without blood. A reminder to panelists to please wait for a group photograph at the end of this session.
Your doctor has just informed you are going to need a big operation, an operation with anticipated significant blood loss. They indicated that your hemoglobin isn't high enough to safely perform the procedure that you require. It is understood that you don't feel comfortable accepting blood products. That's okay. You've been referred to a team of individuals at the Center for Bloodless Medicine and Surgery. This team specializes in getting you prepared for surgery. We will make sure your hemoglobin is high enough that should you suffer blood loss during your procedure, you have extra blood to spare. A normal hemoglobin is anywhere from 11 to 15 grams per deciliter. We will talk with your surgeon about the type of surgery that you need and the anticipated blood loss that can be expected. We will also talk with our consultant hematologist. She will help us to determine what type of treatment is best for you. Our team will determine what your hemoglobin needs to be before your surgery, and we will help you to get it there. This process is very simple. You can do it at home. From your local pharmacy, you will need to purchase a bottle of ferrous sulfate. This is an iron supplement that you can buy over the counter. It is relatively inexpensive, and we have found it to be well tolerated by most of our patients. The biggest complaint we hear is that it causes constipation. While you're at the pharmacy, we suggest that you pick up a laxative and take as directed when you start the ferrous sulfate. This will help you to avoid any constipation problems. Please take ferrous sulfate 3 times a day. It works best if taken on an empty stomach with a glass of orange juice. It's a good idea to take the ferrous sulfate until the contents of the bottle are gone. If your hemoglobin is very low to begin with, this is called anemia, you may need longer to build up your hemoglobin stores. It's kind of like having a tune-up before your surgery. In addition, the iron supplement, you will need to make a couple of dietary changes. You'll need to increase your dietary intake of iron. We usually ask our patients to do a Google search for foods rich in iron. I think you will be pleasantly pleased with what you find. Keep your list handy so that you can refer to it often. You should have foods like red meat, pork, poultry, seafood, beans, dark leafy vegetables, and dried fruit on your list. I think you will find it easy to make these dietary changes. Increasing your hemoglobin using supplements and dietary changes is the safest route to go. It's also the slowest. If you know you're going for a surgery, it would be to your advantage to contact your team at the Center for Bloodless Medicine and Surgery as soon as possible. In some cases, you may not have enough time to increase your hemoglobin using this plan, or you may need a hemoglobin level that cannot be achieved with oral supplements and dietary changes. There are still a couple of options for this scenario. Intravenous iron can be given as an outpatient procedure over a short amount of time. It is well tolerated and, in most cases, associated with minimal risk. We also use a medication that increases red blood cell production, thus increasing your hemoglobin. This medication is called erythropoietin or Procrit, or sometimes EPO. It is given as an injection or it can be given intravenously. Though EPO is associated with more risk than intravenous iron, we have used it very successfully in many of our patients. It is important to have a discussion with your Bloodless team about taking EPO before you decide if it is right for you. Your Bloodless team is always available to help you with your informed decisions to safely avoid blood transfusion. We are experienced and we have many positive outcomes that we are happy to share with you. Please ask us your questions and tell us everything you are thinking. We are here to help.
Thank you very much. Just before we go, I'd like to call on Dick to give us a rundown on tomorrow's programs.
Sure.
Dick, please.
Yeah, please join us for the day 4 of the Bloodless Medicine and Surgery 2024. Tomorrow, your moderators will be Dr. Bruce Spies and Heather Mingo, RN. The presentations tomorrow will be bloodless breast cancer surgery as the standard of care. The next one will be blood salvage in oncology, facts versus myths. And finally, the last one will be bloodless liver transplant with improved outcomes. Please join us tomorrow for this wonderful ongoing presentations of different ideas of bloodless medicine. Thank you for joining us today and have a great day.
On this very good notes, I think we've had a very beautiful day. I want to hereby declare today's session closed. Thank you, everybody. Please join us again tomorrow.
And the group picture, right?
Group picture.
Okay, so the group picture next, and then we join again tomorrow. Thank you.
Have we succeeded with the gallery view? I don't think we have.
I don't think we have yet.
Because you have to remove your spotlight.
Oh, I thought I did the gallery view. Oh, is gallery here? Gallery.
Now it's gallery here.
From my side.
Yes, we have the gallery. I already took the picture.
So, okay, Migo, are you here?
Yes,
okay,
yes, I already took the picture.
Okay, are you ready for our smile? We want to smile when you say so. Okay, so everybody can actually take the screenshot, please. We'll just give a few seconds. I'm trying to practice my own smile.
Ready.
Okay. Are we done?
Yes.
Okay. So, Queen, you have another opportunity to say goodbye.
Okay. So on that note, it's my great pleasure to say goodbye to everybody on today's event. You've been very interactive. It's been a beautiful session. And thank you very much to all our speakers. Very wonderful speakers indeed, simplifying very difficult topics. Thank you very much, Misha and Kyriakos. Maisha Robinson and Kyriakos. Thank you very much, our very able audience. Thank you very much, Miguel, for the videos. And thank you all panelists and participants. At a stage, I think I saw 200 and something participants. That's very good for today. Please see you again tomorrow. Thank you.
Thank you.
Thank you.
Thank you.
Bye.
Yeah, ciao.
Bye.
Yasu.
Yasu.
Yeah.
Great program. Thank you so much, everyone.
Yeah, thank you.
Thank you.
Sandra.
See you
Thank
tomorrow.
you, Maisha.
See you tomorrow.
Bye-bye.
And a big thank you to the moderators.
Yes.
Thank you.